Then I go over to my talk. I'm also having a series of different etiology sort of cases which I thought would interest you because the name was jingling and scintillating. When I was talking to Paridosh about this, he told me that he's going to show a case which is not dramatic in the terms of dramatic, but dramatic in the course of events. So I told him, see, either you have a yow reaction when you go ahead and do a vitreous surgery, or if it is a difficult surgery and you land up in problems, this is what you do, you shit bricks, you know. Okay, so let me start with a wormy beginning. It's a 56-year-old man who was fishing in the mangroves, and he came with the complaints of a lump under the conjunctiva at 11 o'clock meridian, and he also said that he could see a wriggling object in front of his eyes whenever he moved his eye. So we examined him, and there was a lump over here, and when we checked the retina, he had a worm in the retina, so we thought that this would be probably a worm in the upper region too. So the surgery then was done for this patient, where we had to remove the worm from the front part also and from the back part. So this is the removal of the worm. It's always very exciting when you have a worm to remove because it adds another dimension to your surgeries. The normal kick of the surgery is what gets your adrenaline up, you know. So lo and behold, this is a worm which is very long, and this was a lower worm which is it's transmitted by flies, and it's the chrysops fly which transmits this, and this is very common in people who are generally in marshy regions. So in mangroves, etc., this is very common, and this has a kind of transmission through subcutaneous route, and it can migrate through the subcutaneous route. It was there at the ciliary body also, a small worm, and the worm you saw was in the eye also, which you can see wriggling inside. So this was removed successfully and sent for detection of what is the kind of parasite that you're dealing with. Now the second kind of case is that this patient had a 6/6 vision. He had a history of foreign body injury. The scleral perforation had self-sealed. There was just a fine trickle of blood which let you know that there is some kind of a problem at that site. There were no retinal tears. And when the X-rays and the CT scan was done, you saw a small foreign body in this location. Very difficult to move it with vitreous surgery, and if you have to, you'll have to sacrifice the lens and then put in an IOL and then try to remove it, which would be a messy job. So the thing is, the whole thing was to try to remove it without disturbing the vision. So this is where you have to think out of the box, where you have to do something which is probably unconventional, but you go ahead with it. The important thing that the end result is what should be desirable. So a small flap, according to the site of the foreign body, was made in that location, and you made another flap inside so that you have a area to cover it. And this is the point where you cauterize it and make a small nick. And since the foreign body is just lying underneath it, you can just go ahead with your forceps and pick up the foreign body. It was a small stone foreign body which had gone in. And you do a vitrectomy, do a little bit of cryotherapy, and suture back this incision. Now, this case I will keep for later if there's time. Okay, now this is a patient of a 65-year-old. She's a diabetic, hypertensive, had cholesterol issues, and CABG was done in the past. She was on antihypertensives, anti-diabetic medications, on statins and double blood thinners. So she had a cataract surgery for a hard brown cataract. She had a nucleus drop following vitrectomy, and the following vitrectomy, and then the nucleus was removed with the PFCL, and at the end of the surgery, This at the end of the surgery, she developed a suprachoroidal hemorrhage, as you see in this video. It was a hard nucleus which had dislocated inside, and with the use of PFCL and doing a vitrectomy, you take it out of, you enlarge the incision and take it out. It was a really messy kind of a scene. Replace everything back, suture it back, but at the end of the suturing, you see suddenly a gush of red blood appears and there is red mounds appearing within the eye. So you close up, you wait this, an ultrasound was done which confirmed a huge suprachoroidal, as you saw in the previous slide. And then after 14 days, you go ahead and do a suprachoroidal drainage of the blood, and the retina was slightly lifted in one place. So you do the vitrectomy, remove off all the membranes, and I used a buckle in this area because there was a tiny break in that location. Now, this is another patient who had a suprachoroidal bleed somewhere. She had one surgery which was done elsewhere, and the patient was doing well, but later there was some residual blood, and then the patient developed a giant retinal tear, which was like sort of very scrolled and almost looked impossible to do. But the surgery was carefully medically done. That is, there were a lot of subretinal gliotic bands, as you see over there, and these were carefully removed. One really never thought there was a chance in this patient to do well, and the blood was suctioned off from its place, and then slowly after PFCL injection, you find that the retina is settling in the posterior pole, and after doing a retinectomy in the periphery, the ILM peel was carried out, following which all the a retinectomy was done, and then the retina was lasered, and we had the patient with a small island of retina all around the optic nerve where the macula was good, and this patient did develop 660 vision following the surgery. Now, this is a preterm born. How many minutes left? Okay. Preterm born, and this was a 28-weeker, 890 grams. I was not examined at all, and they came to us at 8 months of age. The patient had a 5C ROP with corneal opacification, shallow AC, and a completely closed funnel configuration. This was how the ultrasound looked, and this was how the eye looked. And we kept a graft ready for the patient, and we decided to do an open sky vitrectomy for this patient, where you see the thickness of the cornea, and after the Fleringa ring was put, and after you remove all the membranes, we tackled the periphery because there was a closed loop configuration there, and very slowly, meticulously, all the membranes which were binding the layers of the retina together were slowly removed, and all the time you have to keep injecting your upper visc or agent for sort of separating the layers, and slowly and surely you find that the retina is opening up. The center is already opened up, and then you go ahead and there are no dynamic placements in stage 5 surgeries. You just have to open and leave it alone to go and take its natural place into the back of the eye. And this is at the conclusion, where you finish off with this and then suture this back and await events. This is another patient who had a retrolental membrane. This is a NETA case who was not injected, so the dissection in these patients become very easy. where you can see what you're doing, and there is a gradual delamination of the layers, I mean of the retrolental membrane from the surface of the retina, and slowly you do it circumferentially where you keep separating and go ahead and separate all the layers. I'll fast forward it, and this is like we've done quite a bit of it where you're separating, delaminating, and this is towards the end where you have opened up the central sheath, and the retina just falls back. The important thing is that you have to open up the peripheral trough. And stage 4 case ROP, where you need to remove only what is causing traction. Here you don't really go vociferously after any of those very taut membranes, which sometimes have been created by the use of anti-VEGFs in the eye. So whatever is the traction, leave the macula free, and you can close up the case without really because these cases do well with that minimalistic kind of surgery. And this is another patient where you could skip a beat, because when you're removing the thing, the cannula remains behind in the ciliary body region. So you go ahead, pick up the thing with a forceps, and when you try to remove it, it comes, the enlargement has not been done, so it gets stuck at that site. So you go ahead, enlarge it, and reintroduce the forceps again, hold it properly, and then it comes out. So finally, all's well that ends well. So the moral of the story is never give up.